Good afternoon, everyone, and welcome to the World Heart Day Risk Seminar. Before we begin, I would like to acknowledge the traditional owners of the land which we are coming from today, the Wurundjeri people and the Boon Wurrung people of the Kulin Nation. We pay our respects to the elders past and present and extend that respect to any First Nation elders and community who are joining us today. As I said, welcome to the World Heart Day Risk Seminar, hosted by the La Trobe Institute of Molecular Science, or LIMS, and the Baker Heart and Diabetes Institute, and the La Trobe Centre for Cardiovascular Biology and Disease Research, or CCBDR. My name is Dr. Brooke Whiskas, and I'm really excited to be your host today. I'm a kidney disease researcher here at La Trobe and also a senior lecturer in anatomy. So as some of you may know, World Heart Day was last weekend, and the Baker Institute, LIMS, and CCBDR wanted to take this opportunity to not only celebrate the fantastic cardiovascular research that's happening at La Trobe and the Baker, but also to raise awareness about cardiovascular health, including heart attack and heart disease, and to explore a concept in this space that is often talked about, but sometimes not really clear, and that's risk. So what does risk mean in a heart health context? How much do you know about your heart disease risk? And what can you do to lower it? We'll also be talking about some of the research that's happening at La Trobe and the Baker Institute, which will transform how we treat and prevent heart disease. So let me introduce today's expert panel. We have Samantha Grimer, Dr. Joshua Wong, who is a cardiologist and a PhD candidate researching cardio-oncology and cardiac imaging at the Baker Heart and Diabetes Institute. We have Dr. Maria Jelenic, a LIMS member and a research division lead at the CCBDR, as well as the senior lecturer in human physiology. And we have Professor Peter Meckel, head of systems biology domain, co-lead of the obesity and lipids program, and head of the metabolomics laboratory at the Baker Heart and Diabetes Institute. So I'll be chatting to each panelist, and at the end, we'll be taking questions from the audience. So if you do have a question at any time during the next hour, please type it into the Q&A box that's at the bottom of your screen, and we'll get to as many questions as we can at the end. So enough from me, time to get on to the experts. I'm really excited to introduce our first speaker, which is Samantha Grimer, who is a wife, a mother of 3 boys, and a primary school teacher. So welcome, Sam, to this seminar.
Thank you. Thanks for having me.
Sam, I want you to take me back to around 2021, the holiday season of 2021. Can you tell us a bit about what your life was like then?
Sure. I was, it was just had gone through the Christmas period. So it was busy, as it is for most people. And I was actually transitioning workplaces. So I was moving from one school to another. So it had been a little bit of a stressful time. I was just getting over a bout of tonsillitis, but everything was pretty much as per normal. And then everything suddenly changed because I suffered a heart attack. Very unexpectedly, yeah.
And how old were you at this time?
I was 46. Yeah.
Wow. And so do you mind telling us a bit about what happened,
Sure.
like when you had your heart attack?
Yeah, so it was the 2nd of January, and I was on the way to return some Christmas presents that didn't fit my boys. So I had them all with me, which was unusual in itself, that we don't often go out all shopping together anymore. And on that particular day, I didn't feel all that well, in that I just felt a bit off. It was a really hot day, I remember, and I just felt really tired. But like I said, that wasn't sort of anything unusual. Didn't alarm me at all. We were on our way out. I had my son, who was a learner at the time, driving. So I was in the passenger seat, and the other 2 boys were at the back. And we basically turned the corner from the house, the street that we live on. And I said to them, I don't think I can do this today. I'm not feeling all that well. Let's just turn back. But we passed a milk bar, and I just asked one of my sons to go and grab me some water. I said, I feel like I need some water. I just felt odd, but I didn't know what was going on. And then I did, funny enough, feel some pain going down my arms up to my elbows. And it did sort of trigger me, but I just thought, oh, I'm being silly. It's nothing. It's fine. And I had a bit of an uncomfortable feeling just in my chest, but not a pain, just like as if I'd swallowed a tablet and it was stuck. That's the way I described it to people. That's how it felt. And I had just swallowed some tablets. I had some probiotics, so I thought it was that. And then we stopped at the milk bar and I said to the boys, look, let's turn back. I'm not up to this today. Let's just go home. And in that time, I had passed out in the car and they had driven me home. And when I came to, I was still in the car. My eldest son had opened the door and said, Mum, we've called an ambulance. And I was like, what for? And he said, I think you've had some sort of seizure, because my eyes apparently were opened, but I wasn't responding. And then they took me inside. I don't really remember getting inside. I think I was in and out, and not before too long, very luckily. During that time, it was COVID time. So, ambulances were, very in demand, but I was lucky that my unit got out very quickly and they did what they needed to do. And I was off to hospital within minutes. So I was lucky that, I got the help I needed pretty quickly.
And when did you kind of realize that you'd had a heart attack?
Well, at the time, I really thought I was having some sort of panic attack. I think that Ambos knew exactly what was going on by the way they treated me, and they just kept reassuring me that everything was okay. I continued to pass out on the way to the hospital, and even once I was in hospital. So I didn't know, well, they basically told me after they took some bloods and that protein level, whatever they check, had started to elevate. That's when they said, look, we suspect you've had a heart attack, which was, very like what? And then I was not in a good way. I was, blood pressure was incredibly low. So I kept passing out and I ended up in the resus unit several times. So it was a bit of a dramatic time. I was in emergency for 3 days because there were no beds. The hospital was bedlocked at that time. And it was also a long weekend. So I couldn't have my angio until people came back from holidays, because it was, that New Year's weekend. So it was a lot of waiting, a lot of, a lot of angst, a lot of stress. But they were doing all they could, all the tests that they could. And yeah.
And so tell me a bit about your recovery. What was recovery like?
Look, recovery was difficult. It took me physically, I would say, a good 12 months to start to feel myself again physically, the strength factor, the fitness element. I did have to take it was school holidays, obviously. Being a teacher, I had some time off, but I did have to take 6 weeks off my brand new job. So that was a little bit stressful in itself, but that was necessary. And so all in all, I think I had from the heart attack, about 8 weeks of recovery at home before I went back to work. And it was just a lot of, just healing, rehab. Everything was done online because it was COVID time. So I had all my consultations with, dietitians, with doctors, with physios, all of that, all of the recovery, the exercise, whatnot, counselling, all needed to be done online, which I did. And I was pretty determined to get to work. So I did everything I was told to do so that I could get there. But in saying that, I think the mental and the emotional aspect of having that experience definitely took a lot longer. So I would probably say about 18 months or so. A year ago even, I probably couldn't sit here and talk about it now without getting emotional. I can do that today. It's an event that happened that I can talk about. But before, thinking about it would just take me back and I would tend to relive all those feelings. Yeah.
Understandably, it sounds like a very traumatic experience for it to happen in front of your children as well. And then
especially in front of the boys that was another element. I was concerned for them and what they saw and how they were going to react. And
absolutely. And so through that journey, what did you learn about your own heart risk and heart risk in general?
Immediately after, it happened and I was talking to doctors, the first thing I wanted to know was, why did this happen? I just couldn't believe it that, I was 46, I was relatively healthy, I didn't have any other conditions, You know, I don't smoke. I'm not a heavy drinker. I'm reasonably in okay shape. You know, I've got some weight to lose, but you know, I'm not obese. I'm like, what? Why? What did I do wrong? I remember saying that to my cardiologist. What did I do wrong? And he said, you didn't do anything wrong. This is most likely a genetic event, that there's something in your genes that have made you a risk factor. And the fact that he said that I have Maltese heritage puts me in that risk factor, which was news to me. I was very surprised by it. But yeah, I've since learned that is a little bit of a risk factor there. So
Yeah, I think genetic is the last thing that I think about in regards to risk factors as
yeah.
well. So obviously it's been a while since you've had your heart attack. We're very glad and happy that you joined us here today to share your story. So how has life changed for you since the heart attack?
Okay, so from a health perspective, I guess I've become a little bit more self-conscious of what I eat. I always felt like I had a good diet anyway, but I suppose I'm just a little bit extra careful now. I try to eat, you know, for my heart health. I'm just a little bit more aware. I've tried to include a little bit more exercise in my lifestyle. I'm a very active person anyway. In my job, I'm just generally very active, but I do make a point to try and fit exercise in, which isn't always easy, and I still struggle with that, but I'm doing my best. How else has life changed? I think from an emotional and mental point of view, my perspective's changed. So I don't take things for granted. You know, I try and make the most of every opportunity that comes my way, hence being on this, you know, panel today, because I think it's really important that we, you know, the work that you guys are doing is amazing. And, you know, we need to raise as much awareness because sometimes we're not in control of our risk factors. And that's the position that I feel like I'm in some ways, that things just happen sometimes and you just have to, you know, do the best you can, I suppose, and hope that all the medication you're on, that's another thing, I suppose that's changed for me, is that I'm on lots of medication now. And that was a bit of an adjustment to going from not being on anything to being told, you know, here's a whole bunch of pills that you need to take for the rest of your life. So that was a little bit confronting. I'm okay with it now. I'm really good at swallowing tablets now. But before then, it was, you know, I used to get very emotional filling up that little pill box every week because I felt like this is something an old person should do. This is not something I should be doing. But yeah, that's where I'm at now.
Well, it sounds, I mean, the best outcome possible if you have to take a, you know, little bit of
That's right.
medication
Yep.
and, you know, yeah, I mean, changing your diet and exercise, which was clearly very healthy in the first place. You know, it's amazing that you're still trying to lower your risk factors, you know, today, and are really passionate about it. And again, thank you so much for sharing your story. We will see you in the Q&A, so you'll definitely come back and answer any questions that the audience might have. But thank you again.
You're welcome. Thank you
so much. It's my pleasure now to introduce Dr. Joshua Wong. So Joshua is a cardiologist and a PhD research fellow in cardio-oncology and cardiac imaging at the Baker Heart and Diabetes Institute through the University of Melbourne. After completing his studies at Monash University in 2014, Dr. Wong went on to receive basic and advanced physician training at the Royal Melbourne Hospital, specialising in cardiology. His PhD research focuses on investigating the detection and control of heart failure risk in cancer survivors, which I'm interested to hear more about. He is also the study coordinator of the REDEEM study, a multi-centred randomised control trial investigating the utility and benefits of a heart failure screening program in the adult cancer survivors. Joshua, welcome.
Hi, thanks for having me.
No worries. So Sam told us a lot about her risk or lack of, or genetic risk. And we generally hear about risk and risk factors all the time, especially when talking about heart disease. But sometimes it's not clear what that exactly means. So can you please clarify this for us in the context of heart health? What does risk mean?
Yeah, look, so the heart is a pretty complex organ, and there's no single cause for any one heart condition. I think that's really important to acknowledge at the start. But there are factors that can increase your chance of developing heart disease or a heart condition. And so we term these factors as risk factors. As a doctor, we like to think about risk factors in two kind of groups, as modifiable and non-modifiable risk factors. So that's kind of factors that we can control and factors that are outside of our control. So risk factors like gender, your age, family history, your ethnicity, for Samantha, and genetics, these are non-modifiable, and what you're born with is kind of what you have. And so we have to kind of leave them alone. But then as clinicians, we really like to focus on those that are modifiable. So that's why we really care about, cholesterol levels, blood pressure, diabetes, lifestyle factors, smoking, exercise, diet. Those things are really important because those are things that we can change. But when we assess you, we think of you as a whole person, including those non-modifiable things. And then we add in those things that are modifiable. We try and change what we can. And all that kind of culminates to risk.
It sounds really complex, but I'm glad that you kind of analyze everyone's risk for us, because I wouldn't be able to work that out myself, I don't think. But when you work as a clinician, what are some of the risk factors or common risk factors that you see that might not be so obvious to us?
Look, so that's outside of what I've just said of those common risk factors, yeah, there are other risk factors that aren't as widely known about. And that's usually just because they're just not as common. But we really, take into account previous comorbidities and medical conditions. So we know there's increasing kind of recognition that inflammation has a big part to play in heart disease. And so people sometimes have chronic inflammatory conditions, so inflammation going on all the time, and things like rheumatoid arthritis, lupus, gout, inflammatory bowel disease. Those things can increase your cardiovascular risk because of that kind of chronic inflammation that's happening. But then outside of that, other diseases like sleep apnea, so that can often be linked with things like high blood pressure and again, raise risk. So there are always different conditions definitely that can kind of have that interplay later on of increasing your cardiovascular risk. But one thing that I'm really interested in is not just conditions, but the treatments for conditions. So for my kind of interest area is that I'm a cardiologist that's really passionate about taking care of cancer, people who have the diagnosis of cancer or are undergoing treatments for cancer. And that's because we're starting to see that, as more and more people survive cancer, there's an increase in the amount of kind of heart disease that they're developing. And so we're not sure really if that's a development because of the cancer or maybe because of the chemotherapy they've had or the radiotherapy they've had. But all those things are also not very well recognized kind of risk factor in the development of heart disease. So I think it's important, as a patient that, we think sometimes that when a disease is treated, that it's no longer part of our history and we can kind of put that to the side. But that's not how we assess someone when we're trying to assess you for your cardiovascular risk. We kind of take into account the whole person, their history, the body remembers, those previous conditions and the previous treatments as well that you've had. So they all kind of can have effect on the heart, sometimes even later on in years of life.
That is so interesting and something that I've never thought about before. It's really, really interesting. So when talking about heart disease, we're often told that we need to eat heart-friendly foods and getting exercise and getting good rest, like good sleep, that all helps lower our risk. And but why? Why do those kind of three things help lower our risk?
Oh yeah, look, so this is really important, but it's really quite simple, but I don't think it's maybe explained that well. And so it's really important as a consumer, as someone that's getting this information, that you kind of understand why are we making these changes and what is it actually doing in my body. So we'll start off first with things like the diet, you said, so healthy foods. So we know that it's pretty well kind of recognized that, we think that, eating fats is bad, but we actually know that there are good fats and good cholesterol is really important. So it's not about stopping you eating altogether. It's about you eating the right type of foods, the foods that will increase the good cholesterol and decrease the bad cholesterol that's linked with increasing heart disease. And so those are things that are high in kind of omega-3, we like to say. And so things specifically like avocados, tree nuts, things that are like fatty fishes, so salmon, mackerel, sardines, olive oils, all those are really, really high in omega-3 content. And they're really good at increasing those good fats that we like, and that will lower definitely your risk of heart disease. And that's really strongly based evidence. Your second point about exercise. So look, exercise is not easy to do, I would acknowledge. And we're not saying when we ask someone to exercise that we want you to get a gym membership and we want you to have a whole, revolution in your fitness. But we do know that exercise reduces the risk of other conditions that increase, like high blood pressure and osteoporosis, that later on can, increase risk of potentially heart disease, and keeps your weight down, lowers your risk of diabetes. Those things are great. And so what I usually say to my patients is that, look, I'm not asking you to, all of a sudden lose 20 kilos. I'm asking you to just go on maybe like a brisk walk. And as long as you can get around anywhere between 30 and 45 minutes of moderate intensity exercise. And I say that as like you're going for a walk, but you can't, talk in full sentences. You're keeping your heart up enough that you're actually doing something, and do that, 4 or 5 times a week. And that's enough to try and, meet those kind of targets to try and lower that risk. So those are small changes and lifestyle changes that I think everyone can do. And then the last thing you're saying about sleep, look, sleep is I love sleep. I think everyone loves their sleep, but it's more than just, it's more than just being unconscious. It's about being able to replenish and regenerate and prepare energy for your next day. And so if we don't be able to do that, the body is not able to kind of heal itself. And so we recommend around 7 to 9 hours of sleep per night, because it not only helps with cardiovascular health, but it also is really strongly linked with cognitive function and consolidation of memories and mental cognition and acuity, which is also really vital to be able to achieve those cardiovascular changes that we're trying to do. And all those things work together, and all those things are modifiable to try and improve and lower our risk.
I like that you broke that down into 3 simple things that I could focus on. I love avocados.
Good.
I hate running, but I like walking, so I can do that, and I need an excuse to sleep more. I love that. I can do that. Thank you so much for that, Joshua. We'll see you at the Q&A. I'm sure there'll be plenty of questions for you.
Sure.
But I'd love to introduce our next speaker, Dr. Maria Jelenic. She's, as I mentioned, Maria is a senior lecturer in physiology here at La Trobe, and also a division lead in the CCBDR. And her research focuses on investigating how vascular and kidney inflammation cause complications in cardiometabolic diseases such as heart attack, but also stroke, diabetes, and fatty liver disease. By understanding the role of inflammation in these diseases, Maria aims to pave the way for the development of new treatment strategies which target immune cells in particular, to help reduce organ damage which can occur in cardiometabolic diseases. So thanks for joining us, Maria.
Thanks so much, Brooke.
So your research focuses around the role that inflammation plays in diseases like hypertension, obesity, and diabetes. And these are all leading causes of heart disease. Can you tell us a bit about the effect of inflammation in these diseases?
Yeah, sure can. I might start by explaining what inflammation is, just in case there's anyone that's not sure out there. So inflammation is our body's natural response to infection and injury. It's really important. It's something that's essential. If we don't have an immune response or inflammation, we can get really sick. So you may have heard of patients that are immunocompromised, especially during COVID, where they weren't able to be protected from infections. So it's really important that a person's immune system is working properly. But inflammation, when it's occurring in heart disease or cardiovascular disease, which is, I guess, a broader group of diseases, including stroke and high blood pressure and dyslipidemia or high cholesterol. These are all heart disease, cardiovascular diseases. Inflammation occurs in all of these conditions. And when it's occurring here, it's not necessarily a good guy. So it sometimes is playing an important role in some of these conditions. So we know when we've got a heart attack, we do need our immune system to clean up those dead or damaged cells. So if we don't have our immune response at all, a patient could have worse outcomes. But the immune cells will also play a big role in the chronic disease as it is associated with a lot of these conditions, because a lot of these conditions are happening over years and years. So many patients that do have a heart attack, the immune system or inflammation is driving the growth of the plaque that blocks the artery, that stops the blood supply to the heart. And so that's, I guess, a bit of the role of what the immune system or inflammation plays.
Amazing. It's so complex. Not it's not easy, is it? But it's, I'm interested in what the knowledge gap in this area is. So why don't we know exactly how inflammation is contributing to these diseases?
Yes, very good question. It's keeping me in business as a scientist, this knowledge gap. So what we don't really understand is how we can turn off the immune system so that we still have the protection from infectious disease and our immune system can still clean up any damaged or dead cells, because your cells in your body get damaged just through everyday living. And we have to be able to clean up all that stuff, but we want to be able to turn off the parts that are driving heart disease, kidney disease, brain disease in these patients that are at high risk, as Josh was saying, you know, with their high blood pressure, their poor diets, slightly overweight, those sorts of things. We want to be able to turn off the parts of the immune system that are causing cardiovascular disease in these patients. So one of the ways that we're trying to do this currently, so my group, we use some technologies that can give us information at a single cell level. So this is called single cell transcriptomics. And what it gives us is information about cells in a way that we've never known before. So part of the reason why we don't understand immune cells very well is because there are a lot of different types of immune cells. So if we think about one type of immune cell, there's a large subtype such as a T cell or a B cell, and there are lots of different types of each of these cell types too. So we have, I guess, a theory or a hypothesis that there are specific immune cell types that are playing a role in cardiovascular disease and in certain cardiovascular diseases, and we could potentially stop or block these ones. We first need to work out which cells they are, though. And so that's what we're working very hard here at La Trobe and at LIMS to work out.
Amazing. So how do you see what you're doing now basically translating to benefit patients in the clinic eventually?
Yes, so I am a discovery scientist, so I don't get to interact with patients all that much. This is my interactions with Sam here today are probably some of the most I get, but the hope is that the work that I'm doing or that my group is doing ends up in the clinic. And there really is, I guess, two main things that we are aiming to do. So by understanding the cells that are involved in inflammation in cardiovascular disease, we can achieve two things, or we hope to achieve two things. One is that we want to develop a new therapy for patients where we can target specifically the cell types that are playing a big role in the organ damage and cardiovascular disease. And we have connections with people over at LIMS, as well as with people over at the Monash Institute of Pharmaceutical Sciences, where we can have, they have the technology to design new drugs or to delve into their drug libraries, and they can help us find therapies that may target the cells or the signals that we find out are specific to disease. So this is our, I guess, big goal and what we would hope. But one more thing that we really would like to learn more is how to better predict cardiovascular risk in patients. So when we think about immune markers, one that maybe a lot of the people in the audience have heard of is CRP or C-reactive protein. You may have had that measured in your blood. This is a marker of systemic inflammation. So it can go up for a lot of reasons, but it is known to go up when you have cardiovascular disease. And if you're a patient that has some risk factors, having a heightened CRP level may indicate that your heart is damaged. However, it could indicate that you've had a cold a few weeks ago. So it's not very specific. So one of the things we would really love to achieve with our research is to have a better, more accurate marker of a patient's risk of having a heart attack or a stroke. And so that's something we're working on. And these two aims, I mean, really the goal there is to prevent heart attacks and strokes. And conditions like this, they don't affect everyone equally. They're traumatic and they're very terrible for everyone. But if a patient is, say, in the regions or a rural patient, these people cannot get to a hospital quickly like Samantha could. And so those patients really need to stop this heart attack or stroke from happening in the first place. And I think they will be the patients that benefit the most from this. Now, La Trobe is positioned really well for this because we have campuses in the regions. So we have access to these patients that don't have close access to hospitals. So we're able to see what their needs are and try and address these.
It sounds so exciting, Maria. Can't wait to see where your research goes in the future because, yeah, it sounds like it could really benefit a lot of people, which is amazing. And of course, we'll see you later in the Q&A as well. Thank you so much.
Thanks.
So our final speaker for today is Professor Peter Meikle. He is the head of Systems Biology domain and the co-lead of the Obesity and Lipids program and head of the Metabolomics Laboratory at the Baker Heart and Diabetes Institute. His research examines how alterations in metabolism underpin many chronic diseases, including type 2 diabetes, cardiovascular disease, obesity, and age-related dementia, and also how environmental and genetic factors influence or contribute to or protect us from cardiometabolic disease. This approach is providing an improved understanding of disease mechanisms, leading to new biomarkers for improved diagnosis and risk assessment, as well as new therapeutic strategies to prevent a range of metabolic diseases. Peter, thank you so much for joining us.
Thanks, Brooke. Pleased to be here.
So at the start of this story, we all heard Sam's story and how she did have a genetic predisposition but didn't know about it, which caused her heart attack. Are there any other things that kind of increase your risk?
Yeah, so look, the two main areas of risk come from our genetics and the other area comes from our environment. And now Josh, touched on a lot of those things. So our environment really includes all of the things that we're exposed to. That includes our diet, but also includes things like smoking, includes things like, other pollutants that we might be in contact with just through, where we live and the area that we live in. And of course, even infections, and Josh again touched on those, they're environmental exposures, and all of those things can either increase our risk, but some of them can decrease our risk, as we discussed earlier with the, good diets and healthy levels of exercise and so on. So it's those two, it's our genetics and our environmental factors that are the main drivers for cardiovascular risk.
Great. So can you tell us a bit more about the link between metabolism and diseases like diabetes, heart disease, high blood pressure, obesity?
Sure. So maybe first I can just define metabolism again. It's not necessarily a term that everyone's familiar with, but what we mean by metabolism, it's really the process by which our bodies digest the food that we eat and convert that food into energy to drive our bodies, but also convert it into other molecules or other compounds that we need to maintain our bodies or for growth, depending on the stage that we're at. So there are many complex metabolic pathways by which we convert food into these different factors that we need for maintenance and growth. And that's essentially our metabolism. Now, in a healthy individual, the amount of food we take in and our metabolism and the energy we need is all in balance. And so our metabolic or our metabolism is in a fine balance. Now, if that balance falls out, or if we fall out of balance, either by eating too much, so more than we need, then we have a dysregulation of our metabolism. Again, that's through multiple pathways. It can become very complex, but that dysregulation is typically what's associated with type 2 diabetes, with obesity, with cardiovascular disease.
Thanks for giving us an understanding about that. So your research is all about finding new biomarkers for these diseases. What is a biomarker, first of all, and how do you hope that finding new biomarkers will eventually help clinicians assess risk and improve diagnosis and treatment?
Okay, so many things can be biomarkers. You know, our weight could be a biomarker, our blood pressure could be a biomarker. But I think mostly when we think about biomarkers, we're thinking about these metabolites or compounds that are circulating in our blood. And so cholesterol, for example, is a biomarker, and it's been used for many, many years as a biomarker for cardiovascular risk. So cholesterol is one of the metabolites that I talked about earlier. And again, Josh explained, we have good cholesterol and bad cholesterol. So it's not necessarily absolute amount, although it is related to the absolute amount. So these biomarkers that are circulated in our blood, we have a number that we use at the moment, cholesterol, CRP, and so on. But as I mentioned earlier, our metabolism is very complex. And so cholesterol is one type of fat or lipid that circulates in our blood, but there are literally hundreds of other lipids that are circulating in our blood. And so the work that we're trying to do is understand the relationship between all of these different lipids and which ones of those might be potential biomarkers to improve our ability to assess risk for cardiovascular disease.
Again, amazing, interesting research, Peter. It's going to be really interesting to see, this research come to fruition and actually be translated to the clinic to help clinicians assess risk. It's fantastic work. So thank you, Peter, for joining us, and also to all the panelists in this session. I'm now going to open the session for question and answers. So as I mentioned, if you do have any questions, can you please just type them in the little Q&A chat down the bottom, and we'll try and answer as many as we can. But I guess the first question to all of you, and maybe Sam, we might start with you, is what do you think are some of the biggest misconceptions around heart disease and stroke risk?
Sorry, I was just unmuting myself there.
That's okay.
What do I think are the biggest risk factors?
Or misconceptions about risk?
Misconceptions. Oh, well, I'm probably guilty of having some of those misconceptions myself, in that I thought I was too young, that I didn't fit the category. In my mind, it was something that happened when you were older, something that happened to people that were obese, and something that happened to men generally. I just didn't feel like I fit the profile. And I've since learned that that's a misconception, because lots of people my age and younger can have heart attacks for various reasons. So yeah, that's something I definitely learned along the way.
Yeah, thanks. Josh, any misconceptions that you see in the clinic about heart disease and stroke risk?
I think one of the most common misconceptions is probably what I touched on before, which is that if you have a disease, when it's treated, that's great and it should be treated, but it still contributes some degree of risk. And so, sometimes you ask a patient, do you have any past medical history? And they say no. And then you ask them, and then you see on their med chart that they're taking some statins for their cholesterol, they're on some blood pressure medications. And it's great that risk is being controlled, but there is still that predisposition, and there's still that increase than the normal person with no comorbidities of having some increased risk there. So I think, just acknowledging that even though something is treated, it still affects you is really important.
Yeah, definitely. Thanks. Peter, any ideas about any misconceptions about heart disease risk?
Yeah, look, I think, and Samantha's given us a fantastic story early on. And so I think the misconception is that people who would be classified as low or intermediate risk, I think the misconception is, the assumption is that they have no risk, and that those people don't have cardiovascular events or don't have heart attacks. And that's simply not the case. In fact, if we look at the number of people in the high risk group versus the number of people in the low risk group that actually have a heart attack, the numbers are fairly equal. It's quite surprising that but of course there are many, many more people in the low risk group. So their risk is lower, but there's still a significant number of people in that low risk group and intermediate risk group that go on to have heart attacks. And so that's why it's so important that we develop better biomarkers so that in that intermediate and low risk groups, where we don't necessarily treat them as aggressively as we would in the high risk group, we can identify, who is most likely to have a heart attack and move them into the high risk group where they'll be more appropriately treated.
Yeah, definitely. Maria, any misconceptions about risk of heart disease and stroke?
I think Peter and Samantha really hit the nail on the head there with the patients that are considered low risk. I thought I might just add what those patients are sometimes called, because it's a really cute name. They're called Smurfless.
Oh.
So they're patients that don't have the standard modifiable cardiovascular risk factors. So maybe if there's something so people take away today is that Samantha was Smurfless. And she had a heart attack, and 25% of patients that have heart attacks are Smurfless. So yeah, I think the issue with these patients is we don't really know how to treat them, because normally you would treat the risk factors and they don't have those. So there's a bit of a question then, do we put these patients on statins? Do we give them the same therapies that we give patients that do have the risk factors? There's a bit of, I guess, uncertainty on what the best direction is. And I guess Josh and Peter can correct me if I'm wrong, because I'm not a clinician, but that's my understanding as a basic scientist.
I might ask another question to everyone, if that's all right, because it's still on risk. But what advice can we give to our kids, or I don't know, just anyone we know about risk, or how to limit risk if us as parents have had a history of cardiovascular disease? I guess, Sam, what are you talking to your kids about?
Well, that's a question that I'm really interested in knowing the answer to as well. I have genuine concerns for my own children, that if I have a genetic predisposition to this, well, then do they? And then at what time do we start to act on this? Do we wait till they're over 40, like my doctor keeps saying? Well, I'd rather know now if, we could put some things in place. I mean, I'm a mum like every other mum's, urging their kids to eat healthily, and, they're fairly active anyway. But from the genetic part of things, it is something in the back of my mind that I do worry about.
I guess, Josh, do you do any kind of counselling on this in your clinical work?
Yeah, I think, look, there's two types of, I think, kind of genetic risk. There's actual, like, if you can identify a risk factor that is genetically kind of passed down. So there's like some people have very, very high cholesterol levels, and they eat great diets, but they still have very, very high cholesterol levels. And so we're starting to recognize there are certain types of cholesterols that are more likely to be genetically inherited. There's even a condition called familial hypercholesterolemia, which is a genetic kind of genetic kind of predisposition for high cholesterol. And we do have specific treatments for those things. So people with, very, very high cholesterols and, really strong family history, everyone else in the family also has high cholesterols. Absolutely, that is something to bring up with one of the cardiologists to try and examine you and to test for those things. But beyond that, there is just a, where we can't find a specific gene for it, and it's just maybe more polygenic. So it's just multiple kind of variations in the genetic profile that may predispose to risk. And you're right, it is really scary to know that your kids are more at increased risk. Look, we're currently where there are so many leaps and bounds since 10 years ago in terms of how we can screen for heart disease. Now we can kind of pick up early heart disease when it's quite soft on CTs. We're just trying to work out exactly when's the best time to do these, because there is a radiation effect with doing these screening tests. So what I would say for now is that control what we can control and what we know until we get more information. What we do know is that diet, healthy eating, good rest, those things, and trying to change those environmental factors, things that we can control, try to control. And then those that aren't, we will continue to work within this space to try and improve kind of that screening process. But absolutely, we do empathize and understand that it is a stressful thought for any parent with children.
I might just pick up on what you said, Joshua, because there's a question that kind of relates to screening, which is how do we proactively check for, a clogged artery or a plaque buildup? What are kind of calcium test scores showing us? Are there any other tests that maybe you could get from your GP, like a heart screen test or something that you can get from your GP to kind of, I guess, screen for those risk factors?
Yeah, so look, I think most GPs can do a heart kind of just almost like a cardiovascular risk profile, setting off your cholesterol levels. And if they're significantly elevated, they can also send off some other cholesterol levels that have a predisposition to increase coronary artery risk. They'll check your blood pressure, they'll check your weight and those things. Outside of that, there's a new kind of, or not really that new now, but there's something called a calcium score that more and more GPs are starting to organize. And calcium score is basically like a low dose CT that basically just gives you an aggregate amount of how much calcium is in arteries, which are basically like pipes that surround your heart, and they supply the blood to the heart. So the calcium score can detect, when there is a blockage in a heart vessel, it starts off as kind of quite soft plaque, and we won't pick that up on a calcium score, unfortunately. So in very young people, it's not very useful. The body has to have time for it to age in order for the soft plaque to develop into more mature and then eventually becomes calcium. But that calcium we can pick up because it comes up almost like bone on the scan. And so we can give you an amount, kind of a total amount of how much calcium is in the heart. This is not really a good use, though, for people that have symptoms. So if you have, symptoms of shortness of breath, chest pain, anything actually presenting, it's not a good test for that. But it can give those people who have a couple of risk factors an idea of, is there any impact on my heart, and could prompt, a further consultation with a cardiologist down the line as well, because then there are different kind of targets that we would aim for your cholesterol, different targets we would aim for your blood pressure to try and minimize the risk now that we know that there is some calcium.
Mm-hmm. Interesting. I had one of those too, because heart disease is in my family, and I only just got it, even though we've known for many decades that it's in my family. So I've learned a lot about risk and what I should do as well, which has been great. Okay, so I guess this question is for either Peter or Maria, or anyone can jump in. But so there's been lots of information about how viruses can impact heart health, and given that COVID's still around, we have a yearly flu. There hasn't been much discussion about how these types of things can contribute as a risk factor. Can you speak more to this point, I guess, about viruses contributing as risk?
Maria, you go.
Yeah, I'll take this one. So the answer is a bit tricky. I guess it's not a really simple answer. So our immune system, it has memory, which is one thing. So you can remember when you've had an infection, and that means, and there's a part of your immune system that's really specific. So it can target specific pathogens or bacterial viruses. And so this is something that happens when we get COVID. We have our immune system targeting COVID, especially when it comes back to infect us again. We may not get as sick the second time. So that's why the memory of our immune system is great. We really want that, because it means that we have a good chance of being protected in the future. And it's a reason why vaccines work really well. But I guess your immune system is also trained. So one thing that some researchers around the world are looking at is this training of our immune system. And this is a little bit different. It's not as specific. And what it can mean is that when we get multiple infections or really big infections, later on we may have a bit of a sensitive immune response where it responds more easily. But this is really understudied. And I think that's why we're not talking about it yet, because we don't really know enough. I'm not sure if Peter has much to add to that, but this is a very new concept, I think.
Yeah, just a couple of points to add to that. As Maria said, so if we get an infection, we get an inflammatory response, and that's a good thing, and we need that. But of course, if that inflammatory response doesn't resolve itself when we clear the infection, that's a problem, because that ongoing chronic inflammation increases our risk of cardiovascular disease and many other diseases. What we're starting to understand now a little bit more is that there's actually quite a tight link between our metabolism and our immune system, and how the immune system responds to different challenges. And so there's a whole area now coming out around immunometabolism that's trying to understand that relationship. And so potentially we can start to look at how we can modify our metabolism to affect our immune response and improve our immune response against different challenges. And so again, try to reduce our risk that way. So it is being looked at, but it is still very much in a research stage rather than something translating into the clinic at this point.
We have so many questions, just everyone. Thank you, Maria and Peter, for those answers. So I've only got time to ask 2 more questions. But thank you, everyone. This has been so great. I guess a quick question, hopefully, to anyone who wants to answer it: is stress a risk factor? Maybe chronic stress, a risk factor for cardiovascular disease?
Yes. I'll say yes. I'm sure Josh will say yes to a Peter. Yes.
Yeah, look, stress is always, I think, is a tricky one to define, and stress means different things in different individuals. But I think, yeah, we all recognise that stress is not a good thing for our health, and that's our cardiovascular health and general health.
From my point of view, stress, yes, we know that stress is not good. Just generally, we partake in like worse kind of healthy kind of lifestyles when we have stress. But from a heart point of view, we know that when you have intense stress, and very especially specific emotional stress, can sometimes be linked with a certain type of heart attack. So there's actually a version of heart attack called broken heart syndrome. Well, it's the Japanese word is called the Japanese word is called takotsubo, and it means that the heart basically doesn't pump as well. It has almost like the shape of an octopus when we look at it on an ultrasound, because it doesn't contract anymore. It just kind of sits still. And it's quite clearly linked with, heightened levels of stress. So people often, get these symptoms when they've gone to a funeral, or they've been told of the loss of a loved one. They all of a sudden have the symptoms exactly mimicking that of a heart attack. And when we do all our investigations, we look down their arteries expecting to see that there's blockages, but there's not. The heart is just what we call broken heart syndrome. So is stress good for the heart? No, it's absolutely not.
Is any of that stress linked to inflammation at all? Or we're still trying to understand? Peter, you said it was really complex.
Yeah, look, I'm not... Certainly there's a link between our sympathetic nervous system and stress, and then that links back into our metabolism and to our immune system. So yes, there are links there. Do we understand everything? I don't think so at this point.
And I think the other thing that stress will really play a big role in is your hormones. And so when your hormones are out of whack, and there is a hormone cortisol that is released during stress, that can increase your immune responses, but it can also decrease some of the other hormones that reduce our immune responses, such as in women, estrogen is very protective for our hearts. And if we're stressed, our estrogen levels can go down. So that's not very helpful.
Thank you, everyone. I think there are still questions coming in, so I really appreciate everyone putting their questions in the Q&A, and we will try to still answer them, I think, and get them out to people, because they're all so fantastic. But we're going to have to wrap it up. So if everyone can just join me, I can't see any of you online, but virtual clapping for Samantha for sharing her story, and Dr. Joshua Wong, Maria Jelenic, and Professor Peter Meikle for sharing their expertise for the day. I'd also like to thank LIMS and the Baker and the CCBDR here at La Trobe for hosting this seminar, and it's taken a lot to put everything together, so thanks to everyone who's helped organise this. And finally, thank you to all of you for joining the session. We really hope you found it informative and it's helped to uncover a bit about what risk means in the context of heart health and how you can take charge of your health. I know I've learned a little bit. I'm going to eat more avocados. And also, if you'd like more information about your heart health or about the research that's happening at La Trobe or the Baker, you can just chuck into Google, look for the Baker Heart and Diabetes Institute or La Trobe Institute for Molecular Science. And finally, we'll be sending a feedback form out in the coming days. So we'd really appreciate you filling that in and letting us know what you thought of the day. And that's it. So thank you again for joining us, all of our panelists and everyone online. I'm Dr. Brooke Huskus, and so I hope you all have a wonderful afternoon.
Thanks, Brooke.
Thank you.
Yeah.